Dr. Wendy Chang. She actually put together a lot of these slides. She was originally going to be doing this talk, and due to some situations had to fulfill some other obligations. So I got the opportunity to speak with you all today. But Wendy helped me put together a lot of these slides, so I'd like to thank Dr. Chang for that. I'll start off by saying that I have no conflicts of interest, no disclosures to make. What I'm going to talk about this morning are first some brain trauma cases, subdural hematoma, epidural hematoma, some cases of aneurysmal bleeding, infection, pituitary apoplexy, and then some spine cases here we'll show. So the first case I'll talk about, this is a high school teacher we'll talk about. He was, his wife recalled after he had a fight several weeks ago, family distress argument, he took some nitroglycerin to see if it would help him calm down and relax. He had a brief loss of consciousness at that point in time and woke up with a tender spot in the left head. He presented with cognitive decline, had that ground level fall, had the ground level fall. His physician, naturopathic physician, recommended he be seen in the ER. His medical history was significant for a cabbage, aspirin, and nitroglycerin, as I mentioned there. He, on exam, was slow of speech and gait. He had no focal neurodeficits, but he did have a little bit of pronator drift on questioning him carefully. So, subdural hematomas. This is a bleeding hemorrhage in the brain, or on the brain, I should say, classically caused from rupture of the bridging veins from the dura down to the surface of the brain. These happen more commonly in the elderly because as we get older, our brains shrink down a little bit, and the tension on those bridging veins builds up a little bit, and they're more prone to shear or breakage after a fall. Chronic subdurals classically may happen after a fall. A patient may never even realize they have a subdural hematoma, have no problems, and slowly it may build over time, bleeding slowly. Sometimes these hemorrhages will stop bleeding, but then they organize, they form membranes around them. The membranes then can have secretions and secrete fluid and even bleed themselves and expand. And ultimately, many times they do become symptomatic, but oftentimes these are found incidentally as well. This is the subdural space here. This is the coronal section of the brain here. This is the area, and the bridging veins kind of run right up in through there. We see these commonly in patients who are on antiplatelet agents, aspirin. Also see them on some of the newer Eliquis, et cetera, the drugs that we as neurosurgeons get a little nervous about sometimes, actually. But we also see them all the time in people that aren't taking any of these things as well. They sometimes just happen. So in seeing a patient here, the history, classically the patient will tell you they had a fall at some point in time, although many times though, they don't really recall, but oftentimes you'll be able to trace a fall sometime in the last 3 or 4 weeks or several months sometimes for the chronic subdurals. For the acute subdurals, the history is usually readily apparent. Examination can range from being obtunded from an acute subdural with mass effect to simply headaches. I mentioned before this patient we're talking about had some pronator drift, and what I mean by that is when they were examined, they were asked to close their eyes, hold your arms up in the sky like this, and one of their arms would drift over like this as they close, a sign of some subtle weakness on the motor cortex there. This is a left-sided subdural, so you'd expect this patient to have perhaps maybe some right pronator drift. They may have focal deficits with speech or other things like this as it relates to things, but oftentimes the symptoms for chronic subdurals are simply headaches and very sort of mild findings many times. They may present with balance difficulties or things along this line there. On radiographic findings, classically what we'll see is blood here in the subdural space, and it will track, it'll usually be crescentic in shape, not lens shape. It'll be more of a crescent form on the axial CT scan. So for an acute subdural hematoma after, say, a high-speed motor vehicle collision, in a large subdural, you'll see midline shift where the middle of the brain is pushed from one side over to the other. Those cases often need to go to the operating room for emergent craniotomy, evacuate the subdural hematoma. Sometimes we even leave the bone off and do what's called a decompressive craniectomy. When I was in residency, we used to call that procedure the brain bag, because afterwards their head would be soft for a while, it would swell up a lot. And usually for several weeks to several months, it takes the brain to settle down, and then we can come back later and put the bone back in place. Those are usually, very commonly, how would I say this, obviously emergent procedures, oftentimes last thing you can possibly do. But surprisingly, we have some patients that make some pretty amazing recoveries from this. Unfortunately, some don't. For chronic subdurals, the blood products usually become a little bit more liquefied. We can often evacuate these without doing a large craniotomy, but rather just making a small burr hole in the skull and draining fluid out, 1 or 2 holes, and then placing a drain typically afterwards to allow it to drain out slowly over time. The difficulty with chronic subdurals is very commonly they recur. So there's a lot of debate in the literature over the last 50 years. When I was at the university, I remember reviewing this literature. Do you place 1 burr hole? Do you place 2 holes? Do you put a drain in the holes? Do you not? And some authors argue that as many as 30 to 40% of the time, they have significant recurrence and require repeat drainage there. But very often we can treat these with simple burr hole drainage. So in this case here, this patient presented with an acute decline in mental status. It was a 31-year-old, and this was treated with burr holes here. Onto a different type of case here. This will describe a 31-year-old male who was struck by a truck. He had headache after that injury there. Then he became lethargic and unresponsive. He later then woke up. On exam, he had, at the time that he initially came in, he had no brainstem reflexes whatsoever. He had no pupils bilaterally. He had, his left corneal reflex was intact. And so to test that, basically a Q-tip cotton was put on the cornea on the side there, on the left side, and got a little blink out of him from that side. But otherwise, there's really no obvious sign of brainstem functioning initially here. This patient had an epidural hematoma, which is classically caused from a skull fracture that then lacerates one of the blood vessels on the surface of the dura between the skull and the dura itself. So these blood clots typically occur not in the brain itself, but between the skull and the dura itself there, and then they apply pressure. They usually occur in the younger population, largely, I think, because that's where we see most of our trauma patients. These days, we're seeing the age of our trauma patients, however, is shifting, becoming older and older every year there. So I think we're seeing more of these in an older population as time goes on. It is true that as one gets older, the dura becomes more adherent to the skull, and so we see them perhaps a little bit less over the age of 60. The textbook presentation happens in about a third of these patients, and that's a patient who knocks their head, has a lucid interval. So they're perfectly fine after they knock their head, and then they become obtunded. So this is a axial CT scan of an epidural hematoma here. These hematomas can be distinguished typically because instead of being crescentic like a subdural that runs typically along the whole surface of the brain, it's more lenticuliform here. So sort of pushing into the brain that way, more of a lenticuliform fashion, as they say. It can be sometimes difficult on a CT scan to determine whether things purely an epidural or purely a subdural there. It's obviously, real life doesn't always look just like it does in the text cases. Oftentimes you'll see a skull fracture associated with this, but sometimes you don't see a skull fracture there. Most commonly, epidural hematomas happen from, significant epidural hematomas happen from an arterial bleed on the surface of the dura. We can sometimes see a small vein that can cause a smaller hematoma that usually doesn't expand, usually doesn't have as much pressure, and usually not quite as emergent there. Small epidurals can be managed sometimes medically. Watching them, classically, we'll repeat a CT scan within a few hours to make sure they're not expanding. That particular patient that I showed you before, that patient went to the operating room for an emergent craniotomy and had to return back to their normal baseline. So the next case I'm going to show you is a patient who has the worst headache of their life. And this is a 60-year-old gentleman who said normal activities and doesn't typically complain of headaches, not a migraine patient, not a headache sufferer there, and all of a sudden had sudden onset, worst headache of his life, hit him like a train, thunderclap headache, knocked him down, nothing like he's ever had before. He had a history of hypertension, coronary artery disease, was on aspirin. When he came into the hospital, his blood pressure was 190. He was miserable from his headache, but he was alert and awake and intact. This patient turns out to have a ruptured aneurysm. I'll show you a little bit about this. The peak age of, as you all probably know, an aneurysm is a blister on a blood vessel, happens around the circle of Willis classically. The peak age is between 55 and 60. Risk factors, hypertension, contraceptives, smoking, family history. Symptoms of headache, vomiting, passing out, meningismus, photophobia. Sometimes patients get a third nerve palsy, which will present with perhaps a droop in the eye or a dilated pupil and difficulty with their extraocular movements. 50% of headaches, 50% of patients or more with an aneurysmal bleed will have a sentinel headache. And this is a warning headache that may happen at some point sometime in several weeks before that. Unfortunately, we don't pick these up a lot of times. You know, they just have a bad headache, but in retrospect, you ask them, well, yeah, I had a really bad headache before, and now this one came on, it was way worse. 45% of patients who have a ruptured aneurysm don't survive. This is an incredibly morbid disease. We also see people with subarachnoid hemorrhage or bleeding into the subarachnoid space on the surface of the brain with something called perimesencephalic non-aneurysmal subarachnoid hemorrhage. I could be wrong about this, but it seems to me like I've seen more and more of this over the last 20 years than we saw previous. Some of that may be due to increases in CT scanning techniques. Some of that may be due to, we see this commonly, we see this sometimes in folks with substance abuse, methamphetamine abuse, crack cocaine abuse. We've seen a lot of these as well. But this is a non-aneurysmal subarachnoid hemorrhage that happens around the base of the brain from small capillaries or small veins. It's very difficult on a plain CT to distinguish from an aneurysmal subarachnoid hemorrhage, but a vascular study, an angiogram or a CT angiogram will not show any aneurysm. And typically we'll repeat those studies to prove that it's not a small aneurysm that we're just missing. And these perimesencephalic bleeds can have a very good prognosis. This is the CT scan on a person with a subarachnoid hemorrhage. What we see in this scan, this is an axial scan, so it's a cross-sectional picture through the brain. These are the eyeballs. This is the front, the back. This is the brainstem down here. All this bright stuff here is blood in the subarachnoid space. This is the patient's left side. This is the patient's right side. And we can see it pulls up over here a little bit, suggesting that there may be an aneurysm over here in this area here. Using current technology with CT scans for subarachnoid hemorrhage, the sensitivity for picking up subarachnoid hemorrhage from aneurysmal bleeds is greater than 95%. We'll see about a fifth of patients will have enlarging of their ventricles from the blood. And the amount of blood that we see in the brain, in the fissures here, the thickness of this blood here, that's been shown to be prognostic for developing a complication that can happen after aneurysmal bleed called vasospasm. Vasospasm is a complication related to aneurysms where the vessels around the circle of Willis, thought to be due to the blood products that coalesce there, start to spasm off in a delayed fashion, usually 4 to 10 days after the aneurysm ruptures, and that can lead to strokes and other kind of complications there. So much of the care of aneurysms, patients with aneurysms after they've been ruptured is geared at first preventing rebleeding, obviously securing the aneurysm, but also preventing and treating vasospasm if it arises. So in a patient who is questionable, we don't see a lot of blood on the CT scan, we don't know if it's there or not, lumbar puncture can be done. This is done less and less, I think, these days because, again, the sensitivity of CT scanning is getting better and better and better. But one can do a lumbar puncture, and what we'll see many times is, or at least classically, is this yellow CSF there, indicative of a hemorrhage that's taken place at some point in time. This shows up several hours after a subarachnoid hemorrhage there. One can also look at the red blood cell counts in the cerebrospinal fluid. This gets a little tricky many times in the emergency department because you have a patient who may not be the easiest person to do a lumbar puncture, and they may be moving around. They've already got a really bad headache. You're trying to put a needle in their back to get spinal fluid. You might get some blood from the muscles. You might get a little epidural. Getting a bloody tap is not uncommon. The way we distinguish this is by looking at the blood cell counts in the first tube we collect versus the fourth. And in a patient who has an aneurysmal subarachnoid hemorrhage, classically the red blood cell, the number of red blood cells does not decrease from the first tube you collect to the last tube, whereas if you have a traumatic tap, typically the first tube or two will be more bloody than the last several tubes there. That's one way to try to distinguish it. In reality, most of the times these days, if we've got a patient with a questionable history there, typically they'll get a CT scan, and if the history is really good, very often we'll just go straight to CTA. I think the number of times that we do lumbar punctures to rule out subarachnoid hemorrhage is really going down a lot in the last decade or so. So as I mentioned, CT angiogram is 97% or better sensitive for picking up an aneurysm. That number just keeps getting higher and higher and higher. MRA is a little bit less sensitive. Cerebral angiograms, a classic angiogram. We do this anymore most commonly for treatment. We can treat many of these aneurysms through endovascular techniques, placing coils in the aneurysms rather than having to go to surgery and do a craniotomy and put a clip across it. In highly suspicious cases where you just don't see an aneurysm there, sometimes we will do, on a CT angiogram, we'll do an angiogram. And then sometimes we may even repeat that if it's just so suspicious and we don't believe it's perimesencephalic, but we just don't see anything on the CTA. So I mentioned that hydrocephalus can develop in patients with aneurysms. This is thought to be the blockage of the obstruction of CSF drainage from blood sort of clogging up the drains of the brain, so to speak. Acutely, we typically treat this by placing a lumbar drain in the back. That helps. And sometimes we end up placing an external ventriculostomy drain into the brain to drain it. Most commonly, these patients don't need to have permanent CSF diversion, but there are a number of patients who end up requiring ventriculoperitoneal shunts. Securing the aneurysm is of paramount importance when someone has a ruptured aneurysm and they've actually survived. If someone rebleeds, the mortality is off the charts there. Some say as high as 80%. The rebleeding risk if someone has a ruptured aneurysm is about 4% on the first day, and they've survived the initial bleed. And then it goes up 1.5% for about 2 weeks. Then if you follow those patients for 6 months with an unsecured aneurysm, and this is based on old data from the 60s, 70s, and 80s before we thought it was safe to treat a lot of these aneurysms, rebleeding can happen as much as 50% over the next 6 months. But the risk is really highest in the first 10 days or so there. We can treat the aneurysms most commonly these days endovascularly by placing a coil in through the placing a line into the femoral artery and snaking it up into the brain, and then placing a coil into the aneurysm belly itself there into the body of the aneurysm. This then thromboses off or clots off the aneurysm and secures it. Unfortunately, securing the aneurysm does not do much for the damage to the brain that's already been done. So when we see these patients commonly, they may have significant neurologic deficits if they have a very bad hemorrhage there. And securing the aneurysm generally does not protect them from or cure those deficits there. And that's often a difficult conversation to have with families. That's something that medical management, making sure they have their blood pressure optimized, their ventilation optimized, everything else, their temperature control, blood sugar, et cetera, the whole metabolic workup sort of managed well. That's the best we can do to support them and allow them to recover. But securing the aneurysm is critical because obviously if it rebleeds, that's devastating. I mentioned vasospasm. This typically happens 3 to 14 or 4 to 10 days, depending on how you read after a bleed. We follow this by doing ultrasounds of the brain. Literally, they take an ultrasound and listen to the vessels there through the skull called transcranial Doppler. And you can actually pick up increases in the velocities of the blood in the middle cerebral artery or the anterior cerebral artery or the basilar artery. And increases in velocity there will correlate with narrowing of the vessel and subsequent vasospasm there. We treat this initially. All aneurysm patients get a drug called nimodipine. It's a calcium channel blocker. It's a big, huge horse tablet. It's only able to be given orally or through a feeding tube, so there are some difficulties with it. But it's been shown to decrease vasospasm. They typically get this for several weeks after an aneurysm like this there. Also, in severe cases, vasospasm can be treated by taking the patient down to the angiography suite, and We can inject intraarterial calcium channel blockers such as amlodipine, or even do balloon angioplasty in some severe cases there where a vessel is put in and allowed to expand there. The angioplasty can be incredibly dangerous and is typically reserved for cases where the spasm is quite severe, non-responsive to any of the treatment, and we really don't have any other options. So this is a case of subarachnoid hemorrhage. A patient had progressive somnolence over several hours. We see in this case here some enlargement of the ventricles. The temporal horns here are a little bit bigger. The CTA was negative for a bleed. In this case, when I looked at this, I thought, geez, there might be an aneurysm up in here, but it turned out to be negative and was really what we call the paramesencephalic bleed. And with a lumbar drain and the external ventricular drain, the patient ultimately returned back to their neurologic baseline. So onto a different type of case here. This is we'll show you now a 49-year-old female who 3 weeks ago had an ear infection. Was treated with ear drops and Augmentin, had continued ear pain. Came in with confusion, disorientation, nausea, and vomiting. This patient had a previous medical history of IV drug abuse, but swears she's been clean for a long time. Doesn't touch this stuff at all. Our exam, she was febrile, disoriented, white blood cell count was 23, and she had gram-positive cocci in her blood cells, in her blood cultures. So this is a case of a brain abscess. Brain abscesses, typically we see these commonly in IV drug abusers, hematogenous spread. We can sometimes see multiple abscesses in the brain. We always want to look out for endocarditis, and our medical teams will help with echocardiograms to make sure the heart valves aren't a source. Lung abscesses can also be a source for these. You can sometimes get direct spread from sinusitis or an ear infection. Classically, one of the first case reports of a brain abscess back in the 1940s, I believe, was picked up in the pre-CT days with ear infections. And there was a neurosurgeon, a general surgeon and a neurosurgeon, who actually treated the abscess with a burr hole and then placed a chicken bone, a decalcified chicken bone, into the brain to drain it. This was before we had silastic tubing and rubber tubes and so on. There's actually a great case report about this. I have this in one of my medical history books there. I'm blanking on the name of the neurosurgeon who published that there, but it comes to mind as I look at this. But ear infections, bad ear infections can certainly cause infections into the skull. They can cause mastoiditis and brain abscess as well. So this is some imaging from this patient with a brain abscess. On the left is a CT scan, and on the right side is the MRI scan there. And what we see is this guy here. Not here, but right there. And sorry, I couldn't resist. Abscesses are classically ring enhancing. We see enhancement right here. As you probably know, when we give IV contrast, gadolinium in the MRI scan, this is a non-contrast CT scan, it appears to me, but we use iodinated contrast there. The contrast will go across the blood-brain barrier when there's disruption of the blood-brain barrier. So things like tumors or infection, they'll have a disruption of the blood-brain barrier, so you'll see the contrast actually getting into the brain in those areas there. So when you see enhancement, that's evidence basically of disruption of the blood-brain barrier, and an abscess will classically have a nice clean rim of enhancement there and a dense or a cavity in the middle there. There are a number of other radiographic criteria. I think Dr. Slaughter may show some of that later, perhaps. We mentioned here on diffusion-enhancing imaging, they'll often show what's called restricted diffusion there, so we'll see those there. These typically will get an emergent neurosurgery consult. A mass as big as this one typically will require urgent or emergent drainage depending on the size of the lesion and the patient's neurologic status there. Often we will if we don't have another source, it's important to get a diagnosis there as well. Following drainage, if necessary, antibiotic treatment is universally given, IV antibiotics there. Medical management alone for management of abscesses generally reserved for patients who have very small abscesses, multiple small foci of emboli that are just not drainable, or something that's in a very poorly accessible location. And I can't think of any that would be really poorly accessible, except perhaps in the brainstem. And I can't think that I've ever seen a cerebral abscess in the brainstem personally, but I'm certain it's happened before in the literature there. The mortality from brain abscess is about 10%. And I can tell you from my own personal experience, I've taken a few patients to surgery. It's not always clear if someone has a tumor or an abscess. They look very similar sometimes on the MRI scan. And the patients don't always have the classic clinical presentation. And the few times that I've taken a patient to the operating room thinking it very likely or could be a primary brain tumor, which carries a pretty grim prognosis many times, and we come back, we enter into the lesion there, and we get a bunch of pus back, that's actually a really happy moment for the patient and the surgeon, because the prognosis for an abscess is great compared to the prognosis for a malignant brain tumor. Brain abscess is on those list of things that I really don't want to get in life. When I compare that to some of the other things that can happen there, we see there, it's actually can be a happy moment. I can think of a joyous time I had it. Really happy moment in the waiting room at Legacy Salmon Creek when I walked out and talked to a family and told them great news. She's got an infection in her brain. Sounds kind of odd, doesn't it? In fact, we all had a group hug at that point in time, I think. So the case I showed before had right temporal abscess and mastoiditis. The bug there was strep pneumococcus, which was rare. A craniotomy was done to drain the abscess, so you don't see it there anymore. You can see the burr hole here. You can see the burr hole from the craniotomy. Also, the ear, nose, and throat surgeons did a mastoidectomy to clean out the infected mastoid process there where the infection was going into the bone. And then anti-seizure medication, Keppra is what we classically use now. It's a lot less toxic than Dilantin or Depakote or the more classic drugs there. I would tell you that brain infections, brain abscesses, very high seizure rate relative to other hemorrhages or tumors or things like this. So typically, anti-epileptic drugs are given for at least a short period of time. And this patient did pretty well. Okay, so on to another case. Sorry to keep running this litany of cases here. We'll have time for questions at the end of all our talks today, and so we can come back to some of this if you all have questions there. So this is a case of a 43-year-old gentleman who had sudden onset headache, and he said he couldn't see things right. His vision was getting weird. It felt like he was getting tunnel vision, and he was walking into the doors and just didn't feel like he could see very well. This patient had pituitary apoplexy, and this happens from sudden expansion of a pituitary tumor, an adenoma, from hemorrhage in the tumor or sometimes from necrosis. This is a common presentation initially for pituitary tumors, or it may be from someone who has a known tumor there. There's elevated intracranial pressure sometimes. They can get cranial nerve palsies from expansion into what's called the cavernous sinus right along the base of the skull there. Classically, that causes extraocular movement disorders and often severe pain, severe orbital pain. Visual field cuts can happen. Classically, from a pituitary tumor, patients get what we call a bitemporal hemianopsia. They lose their temporal visual fields. So I always say those patients would be able to stop you if you tried to hit them this way, but they'd be a sucker for a right hook because they don't see things out here on the side there. Of course, we never do that, actually. Very commonly, though, patients will just say they just feel like their vision is just weird. It just doesn't feel right, particularly if there's apoplexy. So these folks will get a CT scan and an MRI scan. This CT scan here shows some expansion into this is the sella where the pituitary gland lives here. I don't see a lot of hemorrhage on this one right here. This is a sagittal MRI scan that shows the pituitary the cellar region right there. And it looks like there's some hemorrhage in that one right there. We'll get a set of laboratories, electrolytes. We're always concerned about the sodium. These folks can get diabetes insipidus and have severe derangements of their sodium. Also, an endocrinologic workup is paramount there. Typically, we'll order these labs here. Medical management right away, hydrocortisone. That's a big deal. That can be life-saving for someone with apoplexy there. We put in urinary catheters classically to watch for diabetes insipidus. And I would say when I was initially taught back at the University of Washington in the 90s and in medical school, I was initially taught that pituitary apoplexy was an emergency that went to the operating room right away. I can remember going to the operating room on, I think it was Thanksgiving Day, 1998, with my chairman, Dr. Wynn, at the University of Washington. I think we did another one on Christmas Day, 1999. It seemed like every holiday, Dr. Wynn seemed to find a pituitary tumor and apoplexy, and so we did these quite frequently there. There's been a fair bit of data and experience that you can take these folks to surgery within a week and have pretty good results. And I think that most of the practice now is to treat these urgently, not necessarily emergently. It varies from patient to patient depending on the mass effect that they're having, the severity of the visual field cut, and how sick they are. Onto a different type of case here. This is a 47-year-old gentleman who presented with weakness over several hours, severe headache, and vomiting. Has hypertension, and this guy just doesn't like taking his hypertensive medications. Just makes him, refuses to take them there. When he came into the hospital, he was moderately hypertensive with a blood pressure of 240 systolic and had an expressive and receptive aphasia and not moving the right side of his body. This gentleman had an intracranial hypertension, intraparenchymal hemorrhage. Risk factors, you see them there: high blood pressure, anticoagulation. Age doubles with each decade after the age of 55. Alcohol use, cocaine and meth. We see a lot more of these than we used to in younger folks with cocaine and meth. I've had 2 patients up in Vancouver who were using a drug that I was unaware of called Kratom. I don't know if anybody here has had patients with that as well, but apparently there may or may not be some link to Kratom use in hemorrhage as well, though that's much less, that's a little bit questionable there. Also, these happen classically deep in the brain, in the basal ganglia. In elderly populations, there's another type of intraparenchymal hemorrhage that happens called a lobar hemorrhage, classically caused from what we call amyloid angiopathy, where the blood vessels become essentially weakened and develop amyloid deposition in the veins themselves and the small arterioles, and they can cause more lobar hemorrhages that are more in the periphery of the brain, more at the gray-white junction and into the gray matter, as opposed to deep in the basal ganglia. Intraparenchymal hemorrhages classically happen in the basal ganglia, from hypertension in the basal ganglia, in the brainstem, in the dorsolateral pons, and in the cerebellum. You can also have, less likely, you can get hemorrhages from tumors, vascular malformations such as AVMs. So here is a rather large blood clot right here. Again, not here, but right there. You see the hyperdense clot right there. This patient has a significant amount of midline shift. The midline runs right here. You can see the ventricles right here are shifted over from the patient's left side to the right side. Initial management involves getting a CT. Obviously, airway, breathing, circulation. If the patient's not protecting their airway, you have to take care of that first and take care of the ABCs in terms of their resuscitation. We like to keep the systolic blood pressure less than 160, typically systolic. This is rather empiric. Ideally, we like to keep their blood pressure normalized, but when a patient that comes in, we don't know what their typical blood pressure is, where they live at. Their blood pressure is going to be chronically elevated classically. Their perfusion is probably going to be, relative to what their blood pressure is normally. So we typically set 160 as sort of the number we shoot for, and we'll use calcium channel blockers. Often an amlodipine drip is started nicardipine drip is started to control that. So Decadron, fairly controversial. Some folks will use it. I typically don't for intraparenchymal hemorrhages, but there are some who do. Mannitol or hypertonic saline, the idea here is to increase the osmolarity and to decrease intracranial pressure there. There's some evidence that hypertonic saline may work a little bit better than mannitol in cases of hemorrhage there, because It doesn't build up in the brain quite as much. And we do surgery sometimes for these hemorrhages, most commonly in the cerebellum, but sometimes we'll do them in large lobar hemorrhages causing impending herniation. The deep intracranial hemorrhages in the caudate nucleus or in the basal ganglia, there's been rather extensive data showing that surgical evacuation of these lesions is not associated with increased outcomes and is associated with worse function. So we tend not to do surgery for those, for most of the basal ganglia hemorrhages. I will say that there has been a push recently with less invasive techniques, fancier retractors, better surgical techniques to sort of readdress this question. I know many neurosurgeons around the country who adamantly believe that the randomized data suggesting that we shouldn't operate on hemorrhages is faulty and not good data there, and their clinical experience is very different there. And I suspect that we may see a resurgence in some operating on some of these hemorrhages in the next few years here, and we'll see how that plays out. But generally speaking, we don't evacuate these clots. We do surgery sometimes on folks who have a large hemorrhage in the brain and it's causing mass effect, and maybe we'll do what's called a decompressive craniectomy. So remove the bone to allow the brain to swell a little bit so they don't die from intracranial pressure. We won't go into the hemorrhage and necessarily evacuate the clot itself because that can cause other kind of damage there. And that's a judgment decision there. There's really not a lot of evidence for that. Typically, we'll do that more commonly on a right-sided or a non-dominant lobe hemorrhage. I will very commonly get a CT angiogram to make sure there's not a vascular malformation hiding out in that clot. If it's a classic location in a patient who has uncontrolled hypertension and comes in with all the classic signs like that, we don't always do that. But sometimes you'll get a hemorrhage that just looks just a little funny, looks a little odd there. And getting a CTA can be useful. Again, one of my last cases as a chief resident was a person who had a big clot. She was fairly young. She was hypertensive, but the clot just looked a little bit weird. This was back in the days when we used to evacuate these before the randomized data suggested that you shouldn't. I took the patient down to the operating room as a chief resident there, called my attending to come on in. He was on his way driving in up at the UW. And I called him on the way and I said, Dr. N, I just looked at the CT angiogram was just done here. It's not a hypertensive bleed, it's a huge AVM, vascular malformation. So he had a few choice words for me at that point in time, just in general there, but very different sort of prognosis. We ended up evacuating some of the clot, taking the patient to angiogram after that, treating some of the AVM endovascularly with thrombosing it with coils and glue and things like this, and then coming back and resecting the rest of the arterial AVM at a later point. That's a rare case, but does happen sometimes. So when we have these patients that may not have a history of hypertension, may be on the young side, the imaging may look a little bit weird, we'll get a CTA. Also, sometimes, if the lesion's not classic, we'll get an MRI and look for tumor, because tumors could certainly bleed. The difficulty here is that it may just show you blood, and the MRI may not be all that helpful. So I'll commonly, if I have a patient that I'm suspicious that the bleed may be from a tumor, I may repeat that MRI scan at some point in time. So brain tumors. I'll make this the last case I show here. So when we think about brain tumors, there are primary brain tumors that occur in the brain, either malignant or benign, and then metastatic tumors. There's a list of tumors that classically we see in the brain. I think breast and lung are clearly the most common. I was always taught that while melanoma is far less common than lung or breast because there's far less cases of melanoma, if you have a melanoma, it's the one type of tumor that's most likely to go to the brain. Does that make sense? Okay. So think back to the scans I showed you before about the abscess. It was a nice, round, enhancing lesion. Here's a brain tumor. Rim enhancing, just like the abscess was, but it's a little bit more irregular over here. On the CT scan, we see a mass right here. It's not quite as hypodense in the middle there, not quite as dark in the middle there. So this a little bit more suspicious for a tumor than an abscess. But if I saw this patient come into if I saw this scan initially, in my mind, I would say the differential diagnosis is tumor versus abscess. So we take the history. Shocker. We put the patient on Decadron if there's a lot of edema around it. If they're having seizures, Keppra, and then we typically will get called for these. So for brain tumors, metastatic tumors with a biopsy-proven primary, and there are multiple lesions there, typically these folks will not get an open craniotomy or surgery there. Typically oncology, radiation oncology, and we often will treat them with radiosurgery, radiation, and/or chemotherapy as necessary. A single solitary lesion in the brain with no known diagnosis almost always will get a craniotomy to get a diagnosis, and also for mass effect if the tumor is causing significant mass effect. For metastatic lesions, the best randomized data that's out there is that for a patient with a single metastatic lesion, surgery plus radiation is better than either of those treatments alone. That data was generated before some of the major advances in radiosurgery have been developed in the last several years, so there are some who would debate that. But the randomized data still suggests that surgery plus radiation is the best treatment there. And to my knowledge, there haven't been any new level 1 studies that have sort of countered that. So this is the patient. That patient underwent a left frontal craniotomy and had a resection, and this is one of Dr. Chang's patients who had to return back to their baseline. How much time do we have? I got 5 minutes. Okay, so I'll show one case of spinal cord compression here. This is a 45-year-old female with several days of neck pain and gait instability and clumsy hands. History of IV drug abuse, and was injecting heroin directly into the neck here. Couldn't have any more veins here, so went right into the neck directly there. On exam, had wobbly gait, hands couldn't control, had a Hoffman sign, so he flicked the fingernail and the thumb would kind of collapse down like that. Upgoing toes on Babinski testing, and severe hyperreflexia. There had a white blood cell count of 23, an elevated CRP and SED rate, and blood culture is positive for everybody's favorite staph culture, MRSA. So cord compression can happen from disc herniation, epidural abscess, tumor, fracture, or post-op hematomas. People can get numbness, weakness, urinary retention, clumsy hands, spasticity, upgoing toes. This is the imaging in that patient I was just talking about here. And what we see here is an MRI scan, sagittal, and right in this region in here, there's a lot of pus right around the cord here. This is the vertebral bodies right here, the spinal cord running right here, and this is all our infection here, just squeezing off on our spinal cord. So because of our neurologic deficits, this patient was taken to surgery emergently to decompress the spinal cord, also to stabilize the spine. And it seems counterintuitive that you would have an active infection and want to put hardware in to stabilize the spine, but there's actually really good data and a lot of experience that you can actually, with titanium implants, you can actually put them in infected cases there, and if you restore stability and treat the infection aggressively, they don't have significant difficulties with the hardware. In that case, what was done was a laminectomy was done posteriorly in the back, and the pus was drained from the front of the spinal cord by using a little hook to reach around the spinal cord and drain the pus out of the front. And then rods and screws were placed in to stabilize the spine so that she didn't have further collapse. I think we'll end with that last case there. Okay. All right. Thank you, Brian. So one more case here. There's a 34-year-old female with right greater than left lower extremity weakness and pain. Can't walk, is numb when she sits down, and incontinent of urine. She's had multiple spine surgeries somewhere else in the past there. So this is what, any guesses as to what we're worried about here? Okay, bingo. Thanks. So Cauda Equina syndrome, it's everybody's, it's a buzz term, and what everybody we worry about in the emergency department, in our office, or anytime we see a patient with back issues. It can happen from compression of the nerve roots in the Cauda Equina, From a massive lumbar disc herniation is probably the most common cause of this, very commonly in the setting of somebody with pre-existing stenosis. So they have a narrow spinal canal to begin with, and then they herniate a disc on top of that. At least that's when I've most commonly seen it there. It can also happen from infection and abscesses. It can happen from fractures, or it can develop from postoperative epidural hematomas here. I would say that the Cauda equina syndrome is really a continuum. I mean, the classic Cauda equina syndrome we worry about is incontinence, is saddle anesthesia, loss of rectal tone, and such. But there can be mild variations of this. Patients may not have incontinence. They may have urinary retention. They may have some elements of the Cauda equina syndrome, but not the full-blown Cauda equina syndrome. These are some of the symptoms and the exam. I would say that if you're really worried about Cauda equina syndrome in somebody, it is imperative to do a rectal exam. That's critical from a clinical standpoint, take care of the patient, but also from a medical legal standpoint. And while you're there, also check perianal sensation and perineal sensation. So this is an MRI from a person with a Cauda equina syndrome. What we see here at L5S1, we'll call that there. It's hard to number these based on this image here. That's probably L45 actually. We see a large herniated disc there and severe stenosis in that region. So the best medical evidence suggests that outcomes for recovery of bowel and bladder function when it's lost, outcomes are better if you operate within the first 48 hours versus after that. That being said, I don't know any neurosurgeons or orthopedic spine surgeons who would sit on a patient with Cauda equina syndrome for 47 hours while it was there. We usually take them to the operating room at the first safe opportunity. I have had some patients who have had other medical complications, and at the time I didn't feel like it was safe to take them at 3 o'clock in the morning until we made sure that their heart was clear and things like that, and that I think is reasonable there. But most of us will treat this and get them to the operating room ASAP. We want to do decompression in the case of the discectomy like before, or take out tumor, or stabilize a fracture, or drain the abscess. Most of the case reports and series have demonstrated the outcome depends on how bad they were before the operation there. So that case underwent a microdiscectomy and had resolution of their symptoms. And so, in summary, patients with acute neurological changes may require emergent intervention. Always want to take a good history, do a good exam, CT and MRI when appropriate, and a neurosurgery consult. And those are Dr. Chang's 4 beautiful children. She couldn't be here today, but wanted to share that picture with us today. So I thank you for your attention and going through this case with us, and we'll go on to the next.